And it's my great opportunity for me to say the word today among our beautiful ladies around me. The role of the woman in our modern society requires self-confidence and initiative, preservative, and inherent desire to work. The woman has been proved to present time that they can adopt to develop of the society, economic and political circumstances are surrounding them. The role of the woman in the medical field is to concentrate a fundamental role worldwide. And various medical specialists, where they are a doctor, nurse, midwifery, or a community health worker. A woman in the era of the medical, they have management, they are managed and succeed in the hospital management, and they have their own medical achievement. We were able to obtain some of them, they are able to obtain a Nobel Prize, and many female doctors have proven their ability to combine scientific and medical competency. So they were able to prove to importance of their leadership role in the health sector through their many achievements and effective role that contribute to the important health service. History, a witness made promise name of female doctor who have been distinguished and result of their effect in their development of the medical field. Today we are among them, and my pleasure to be a chairperson in the section that including distinguished and well-known ladies as ophthalmologists in ophthalmology field. And now I like to welcome Dr. Erika Iskana, if I am right.
Yes.
Her talk in the correction deep corneal obesity with the customized trans PRK, and what is the important to take into the account while planning to customize ablation. Okay, Dr.
Thank you, Dr. Fatima, for the introduction. I would like to share my screen now, and I would like to get feedback if it is visible now for everyone. Is it?
Yeah, it is.
Okay, great. Then I will start, and first of all, let me say hello again and express my gratefulness for the invitation for this permanent symposium and for the honor to open the Women Ophthalmologist session. So my presentation is devoted to the challenging situation when we need to correct the corneal irregularities and high corneal aberrations using a surface ablation, and it requires a certain knowledge and experience to do it in the right way, and I'm proud to share this information. So my presentation is structured as the following. First, I will describe a few clinical cases where I was using the corneal wavefront aberration treatment. I also performed a literature-based and mathematical analysis of aberration-free and corneal wavefront treatment plans, and would like to make a conclusion out of it. For all cases, the standard refractive examination for all patients was performed. Corneal aberrometry and papillometry in different light conditions were performed, and ablation was planned with a shrink cam software and trans-PRK ablation with a SmartSurf technology performed on Schwinn-Tamaris excimer laser. First of all, let me say a few words as a reminder on what does it mean a single-step trans-PRK. This is a combination of two profiles, PRK and PTK, in one software solution, which allows us to avoid the problems connected with epithelial thickness and with undercorrection in cases of thick epithelium. This profile can be realized in spherical and corneal wavefront profiles, and the main difference is that Pierke refractive profile is applied first on the cornea, and then in the same procedure, the PTK profile comes. So refractive profile is definitely delivered to the cornea. SMARTPULSE technology in surface ablation has a name SMARTSURF, and it removes the corneal irregularities and improves the corneal smoothness, and it improves the short-term visual outcome. At the same time, it does not influence the refractive outcome, and it's based on 3D Fuller-N model. First clinical case which I would like to show is a 41-year-old woman who was a long contact lens wearer. She overcame keratitis on the right eye 3 years ago before she came to the clinic. And afterwards, unfortunately, the visual acuity, the BCVA, was reduced, as you see, until 0.5. Here are the other measurements which we performed, and you see how high are corneal aberration in this case. So here you see the corneal opacity, the corneal wavefront, the topography data and PSF data, as well as OCT information, where you can see that the corneal opacity lays in the depths between 116 and 178 microns. The treatment plan in this case was decided to perform refraction-free trans-PRK customized corneal wavefront customized ablation with optical zone 7.5 millimeters. The ablation depth 125 microns and the residual stromal thickness 417 microns. In this ablation plan, only 50 to 59 microns were refractive component, the rest is epithelium ablation. So in this slide, you can see the comparison pre-op and post-op 6 months, and you see how the topography and the barometry changed and the corneal transparency changed, as well as OCT data. 6 months post-op, you can see that visual acuity of these patients was high enough and BCVA improved until 1,0. You see that refractive effect, in spite of we didn't implement any refractive component in the treatment plan, was 2,25 diopters, and the corneal aberrations decreased significantly. Analyzing the literature, we found out that there is a difference in depth of the ablation, which is tolerable to a refractive effect. And it depends on the optical zone which we decide in each case. So, for example, in a 7 millimeter optical zone, the tolerance depth is 13-15 microns, and it corresponds to 0.75 diopters aberration-free treatment for selected optical zone. And now I would like to share another case, which I would like to perform in another way now knowing this information. This is a 33-year-old patient whom I was observing at the end of 2017. I was invited as a reference surgeon to consult the difficult cases. And here you see the preoperative data of this patient, and you see that it's relatively high myopia. Everything is okay, but 6 months post-op, when I met this patient, I saw that right eye was relatively okay, but left eye, you see the visual acuity is low, the BCVA is reduced, and the refractive component is also changed. And I have observed a linear scar on the cornea, which probably caused an irregular astigmatism. You see this scar on the picture on this slide. The topography was looking it was looking like a keratoconic case, but it was not. And OCT, you see several corneal irregularities on this case, and pachymetry data was the following. The lower part of the cornea was thinner than upper part of the cornea. As a fact of our examination, we found out that patient had an irregular flap formation during convenient LASIK, and part of the flap was lost during the surgery and later filled with a corneal epithelium, as you see here. So the complication was looking approximately so. And I decided at this moment to perform the treatment in the 2 stages. First, to correct the corneal aberrations and to get the manifest refraction. And the second, when the manifest refraction is clear, to correct the rest of ametropy. And you see that here is also a refractive-free ablation planned, but the ablation depths, excluding epithelium thickness in the middle of the cornea, approximately 10 microns, and the maximal depth is 23 microns. Now we know that it should not influence in the optical zone 7 millimeters any refraction. So, and 1 month post-op, we got 0.9 BCVA in this case, and the refraction was more or less clear, and the cornea was more transparent. You see the topography data 1 month post-op, and you see the OCT data 1 month post-op. So, as a conclusion, wavefront guided treatments take more tissue than aberration-free treatments with equal manifest refraction values. This leads to the fact that wavefront guided treatments do have a higher potential of overcorrected outcomes. A certain depth volume difference, depending on the optical zone, is tolerable of high order aberrations, should be a part of the treatment plan. If the differences are larger than these, the surgeon should modify the spherical and cylindrical component until the difference is within the range for the selected optical zone. Otherwise, the risk of the postoperative refractive outcome differs significantly from the target is existing. Thank you very much for your kind attention.
Thank you very much, Dr. Erika. Now we are welcoming to Dr. Zainab Akhtas, talking to us about primary congenital glaucoma, tips to improve treatment outcomes.
Hello, everyone. You hear me?
Yes, we are hearing you.
It is a great pleasure for me to be here, dear colleagues. Actually, I would like to thank you for organizing such a great meeting and especially for this session, for this special Women in Ophthalmology session. So thanks again for the invitation. So as you said, I'm going to talk about tips to improve treatment outcomes in patients with primary congenital glaucoma this evening. So it is actually the childhood glaucoma is a very difficult and important disease. Actually, it is difficult because it constitutes childhood blindness. It constitutes up to 18% of childhood blindness, and it's difficult because of the different anatomy in kids, and it's the difficulty in medication use in kids and associated ocular anomalies and the difficulties we are facing with in general anesthesia or amblyopia issues. And primary congenital glaucoma is the most common cause of non-syndromic glaucomas in kids. So the success in these kids are mainly dependent on diagnostic pearls and surgical pearls, actually. So today I'll be talking mostly on diagnostic and surgical challenges and mostly on Schlemm's canal surgeries, since it's difficult to cover all kind of surgeries in this kit. So first of all, we need to diagnose this disease correctly. So let's remember the Childhood Glaucoma Research Network diagnostic criteria for primary congenital glaucoma. So basically, we need to have at least 2 of these criteria as follows: IOP, high IOP, more than 21 millimeter mercuries, and optic nerve cupping, and corneal findings, progressive myopia, and visual field defects for sure. And as we all know, measuring intraocular pressure in kids is a bit tricky because of these problems, cooperation movements, anesthesia problems, and speculum pressure and different biomechanics in kids. So we have actually more reliable parameters other than IOP, like HAP, citria, like morphological changes in bulbus, like high iris insertion, change in refraction, secondary to increased axial length, etc. So, other than that, we need to know differentials of these disease. So a cloudy cornea doesn't mean that your patient has a primary congenital glaucoma. This might be a congenital hereditary endothelial dystrophia. For example, if you have a corneal clouding, but if this is an only finding and you don't have any increase in corneal diameters, increase in axial lengths, and if you can see the optic nerve, there's no change in the optic nerve, this might be endothelial dystrophia, and it might be sometimes difficult to differentiate it. And this is a kid with megalocornea. Sometimes it might be difficult to differentiate it too. And in this kid, there's no increase in intraocular pressure, and there's no HAP citrate, there's no morphological changes in cornea, and there's no increase in axial length and optic nerve change. So this is just an isolated megalocornea. And sometimes in patients with primary congenital glaucoma, in mild forms, and they might be presented with atypical findings like this. This is a 14-year-old kid with acute decrease in visual acuity, and actually the high IOP in the optic in the right eye for the first time. It was around 40 millimeters mercury. When we have a closed look into the cornea, we saw the HAP citrus actually on the cornea. So this is very specific finding, and we checked the angle was looking very dystonic. So these are typical findings of congenital glaucoma. And when we look at the fundus, and there is an ischemical changes in the retinal layers, so patients was diagnosed as a primary congenital glaucoma presented with pericentral acute middle maculopathy with PEM. So these are atypical presentations. So let's have a look at our flow chart. So in kids with primary congenital glaucoma, we actually need to start with angle surgery, and we can repeat angle surgery if it doesn't work out. And if it's not circumferential, you can go ahead and complete it 360. And then if it doesn't work, you can go ahead and do tube surgery or trabeculectomy, or you can add medication or diet laser. But in every step, we need to evaluate our patient's visual potential before further intervention. So this is classical ab externa surgery in patients with primary congenital glaucoma. And in this cornea, you don't have a chance to do ab interna surgery. This is my preference. I create a radial scleral incision in the limbus, and to find Schlemm's canal. You cannot find the Schlemm's canal in every kid. It's about 15%. And after performing paracentesis, we are trying to find Schlemm's canal. This is just anterior to the scleral support as a whitish band, as you see here. You can also see the blood reflux coming out from Schlemm's canal. And once you're in the canal, you use Harm's trabeculotome, and you slightly rotate it towards the anterior chamber, and paying attention to corneal endothelium, of course. So what about the outcomes of circumferential and conventional angle surgery? Circumferential surgery is expected to, of course, has a higher treatment outcomes, as you see here in this paper. And this is our clinical study in which we performed trabeculotomy, circumferential and conventional trabeculotomy in neonatal onset primary congenital glaucoma. And our findings also was supporting to the current findings of current literature. Circumferential trabeculotomy had a higher rate of success. So we can do circumferential trabeculotomy with suture and also LED lighted catheter, and it's the cheapest way to do this surgery. I'm generally using the Prolene suture, 5-4 Prolene suture to do this in kids. We are trying to find Schlemm's canal, as you see here. Once we find the Schlemm's canal, we grab a 5-4 Prolene suture and have the distal tip blunted and insert it into canal. You can follow the tip of the suture advancing parallel to limbus, as you see here. And also you can easily put the corneal lens over the cornea and check its position in the Schlemm's canal, as you see here. It's in the canal. This is the case with posterior embryotoxon. Once you grab the distal part of the suture, you grab it, and you can externalize the suture tips through another paracentesis and slightly pull it. And at this stage, you need to be careful because there might be a strong adhesions between the iris and the posterior embryotoxon. And then we can do 360 circumferential trabeculotomy, as you can see here. So during these cases, one of the most common complications is false passage, as you see here. And if you follow the tip of the suture, it goes posterior to the bulbous. So this is an example for false passage. So in those cases, they can create these kind of scars in the posterior segment. So when it comes to GAT, this is one of the favorite procedure. If you have a kid with nice clear corneas or moderate to mild to moderate corneal edema, you can easily do this procedure. It has a learning curve, but it's my primary procedure. And according to my friends, Dr. Grove's paper, actually, this surgery has a promising results in kids with primary congenital glaucoma and juvenile open-angle glaucoma. But in dysgenic angles, it has some tricks, it has some difficulties. First of all, working right behind the edematous cornea sometimes can be difficult, especially in the very beginning of the surgery. As you see here, we don't have a nice surgical corneal view. And once you find Schlemm's canal, you can slightly push the posterior lip of the canal, trabecular meshwork, and then try to see where you are. And once you see the nice posterior wall of the Schlemm's canal, you push the 5/0 pro-lens suture with a blunted tip into the canal. You can see the nice reflux bleeding from the epicycleral veins during surgery. And at this point, you might need to inject some viscoelastics to increase the visibility of the suture. And then you keep advancing the suture till the time you see the distal tip of the suture coming out of the canal, as you see here. And then you grab the suture and pull it so that you create internal 360 trabeculotomy here in this kid. Another trick is, another difficulty here in this kid's angle is dysgenic, and an iris might be too high, so that to find the Schlemm's canal, you might need to pull the iris root just a little bit back using your surgical instruments, your blunt spatula, or whatever you feel comfortable with. And during these surgical maneuvers, sometimes these vessels might bleed, and then this might obscure your surgical view. At this point, you need to stop and inject some viscoelastics and irrigate anterior chamber, actually, to see the angle. And in dysgenic angles, also the suture might stop in the canal, and then you try to advance the suture in other direction, as I did here. Okay, what if surgery fails? What should we do? First of all, we need to know kids with poor prognosis. As we all know, kids with high corneal diameters, higher than 14 millimeters, and earlier presentations, earlier than 3 months or later than 2 years, are kids with poor prognosis. So according to the literature, with primary external surgery, we need to operate these kids, reoperate these kids in almost 30%, at least 32% of cases. This is actually similar to our results. In our clinic, it was in our patient series, it was around 40%. Of course, it depends on the disease severity. So how to decide to go further? Of course, we need to follow our patients lifelong, and we examine them under general anesthesia and look for these parameters again: IOP, axial length, corneal diameters, appearance, corneal appearance, optic disc, and angle examination. And during these examinations, we need to pay attention to morphological changes again. If we see increased cup to disc ratios, or if we see some some scleral thinnings, especially in our previous surgery areas. This is very important finding, and this necessitates, and it tells us we need something. Something more. So we can do retrap. If we did previously a conventional surgery, we can go ahead and open up the trabecular meshwork distal system in the rest of the angle. You see here in the nasal angle, we did conventional trabeculotomy surgery, and right next to it, we are still we still have a space for trabeculotomy. We are creating radial scleral incision and trying to see the scleral, see the scleral spore and the Schlemm's canal. Once we find it, as you see here, there is a blood reflux and aqueous percolation, and then we insert the suture. And as you see, cornea still has a corneal edema. And then in these cases in which we are performing a second surgery, we might expect this catheter or this suture might hit the previous surgery area and then get into anterior chamber. So we need to pay attention to the iris and pupil movements if it enters the anterior chamber, because it hits iris. And this is what happens here. And there we see here the pupillary movement, and then we saw that the suture is in the anterior chamber. Probably it hit this previous scarred area, and then we grab the distal part of the suture, as you see here, and pull it, so that we had a nice trabeculotomy in the rest of the angle. So that we did a retrabeculotomy in these cases instead of doing trabeculectomy or putting the tube in. So let's remember the flow chart in these cases. So you can repeat the angle surgery again if it doesn't work out for you, and then you can put the tube in, or you can do trabeculectomy with mitomycin C. I'm not a big fan of trap and mitomycin C application in kids, and if it doesn't work, I generally perform diode laser and tube surgery, and of course, I add medication. And at the end of my presentation, I'll show you a couple of cases. This is a kid with primary congenital glaucoma, aged 2 months, and the axial length was 19 millimeters. And after external trabeculotomy surgery, after 5 months, patient has still high intraocular pressures. On the other hand, axial length and corneal diameters look stable, and optic nerve looks stable, but there's still high intraocular pressure. At this point, you can add just simply one medication and follow up this kid. And this is another kid with a primary congenital glaucoma, but it's severe case. As you see in the central area, cornea has a stromal scar. Here, the 4-month-old patient, and IOPs are in 30s, and axial length is 20. We start with trabecular trap in this case, and then after a couple of months, patient still has a high intraocular pressure, as you see here, and with an increase in axial length, so that we go ahead and put the tube in this case. And after a couple of months, she still has high intraocular pressures, but it's low, but it's still around 20s. And then we add limited diode laser addition in the inferior quadrant. So to conclude, it is a difficult disease, and it definitely requires lifetime follow-up. And the results of the treatment mostly dependent on the associated ocular and systemic anomalies, for sure, and of course the severity of the disease. And treatment in these cases is mainly surgical, but additional medications and further surgeries are mostly needed. And as a last thing, but the most important thing, we need to evaluate the visual potential in those kids in every step before planning further surgical treatment. Thanks so much.
Thank you very much, Dr. Zainab, for your exciting presentation. I leave the talk for Fatma Ibrahim.
Okay, I'd like now to invite Dr. Nancy Raghet to give her talk in a woman surgeon in the time of the COVID-19.
Good evening, everybody. Let me just share my screen first. Good evening again, and I'm very happy and pleased to be sharing this session with you. I thought, since this is the first women ophthalmologist meeting held in the Middle East, and it's one of a kind, I thought that I would give it a little bit of a spice and not talk about only scientific content, because we can share our scientific content and experience with all our colleagues, males and females. So I'm not supporting the idea of having a special session for the women, which I'm sure in many aspects, sometimes they outperform their male colleagues. So I wanted to share my experience as a women's surgeon during the time of COVID. And sometimes life works against what we think we can control it. To start with, we all know that COVID had changed our lives forever. And the magnifying glass of COVID-19 has pushed us to look closely at many hidden aspects of our profession. Many expectations expressed by some that women doctors would make adjustments in their professional roles to accommodate their personal roles. My talk today will be about. Okay. So, yet it never occurred to my mind, as I chose the title for my talk, that I will be living this title in the finest details. I'm writing this presentation and presenting it while accompanying my father and now my mom in hospital as they fight against COVID-19 infection. Shuffling my ever-expanding duties as a cornea and refractive surgeon, a wife, a mom for 4, an officer, a researcher, and a women's advocate. With lack of time, lack of sleep, and definitely lack of ideas. So instead of speaking for women ophthalmologists, which was my main idea here, I decided to let ophthalmology speak for me this time. I decided to share a video of one of the challenging cases I came across and how I managed it. A case I call my COVID case, not because it is related to COVID-19 in any way, but because it reflects how during the darkest of times that you get to appreciate the brightest of rays. I'll let the video to speak. I would like to show how I performed phacoemulsification on a 24-year-old male patient. He's one of 3 siblings who have the same condition of extreme nanophthalmia with axial length of 13 millimeter. The wide-to-wide diameter of the cornea is 9.5, and the IOL power is 62 diopters. Before surgery, I would like to give my patients Diamox acetazolamide tabs on the night of the procedure, and half an hour before surgery, IV mannitol to decompress the vitreous and to decrease the positive posterior pressure. I do the phacoemulsification under gentle settings, and I use a lot of viscoelastic to keep the AC maintained most of the time. As this is a very soft cataract, I took it out with the epinucleus setting, and it's better to do the procedure early. First of all, you decrease the risk of glaucoma because you remove a relatively large volume of the lens. And the second thing is that you decrease the risk of complications by leaving the lens to become harder and then having to deal with more complications and more risky states. So I take out the lens with the cortex out, and then I inject a lot of viscoelastic. And the lens or the IOL that's used in these cases is a customizable special order CT Extreme lens from Zeiss. And it offers you a high dioptric power, although it is a thick lens. And the concentric rings in the lens just add on the power of the lens. I like to test how smoothly it glides in the injector before injecting it. And then upon injection, I like to inject it halfway, and because it has the tendency to spring out of the injector, and also the posterior capsule has a higher risk of rupture in these cases. So to be as gentle as possible on the posterior capsule, so I inject the first 2 in the bag, and then tuck in the second 2 haptics manually with my second instrument, which is a Sinskey hook, and I take out the viscoelastic, and that concludes the procedure. Now, this is the second eye of the same patient as in the first movie, and I've done almost the same precautions to decompress the vitreous, to use a retrobulbar, to avoid retrobulbar anesthesia, and to use intracameral and topical anesthesia, and also to use gentle settings, and use a lot of viscoelastics, and everything went okay. And I was reassuring the patient that we are almost done, and that I'm injecting the lens the same way I've injected in the first eye, but you cannot always predict what will happen next. So at that moment, the patient started to feel some pain, and the iris started to behave in a weird way. And as you can see, it started, the anterior chamber started to shallow, the pupil started to close on the lens, and there was a positive posterior pressure that did not allow me to tuck in the remaining 2 haptics of the lens that were still stuck outside of the bag. So I was stuck with a situation that I had to manage. So I started to avoid the panic, the feeling of panic inside myself, and started to prioritize what I'm gonna do. So the most important thing to avoid here is a suprachoroidal hemorrhage. So I thought of suprachoroidal hemorrhage as the first choice, and I started to palpate the eye and to see that there's no doming in the posterior pole, and excluded that possibility. The other possibility is a malignant glaucoma, and that would be associated with shallowing and tense eye, but the eye was not becoming very tense at that moment. And the third possibility is a iris or pupillary block, but I excluded also that by just manipulating the iris and breaking any block. So I've given the patient IV Diamox inside the operative room, and I've given him some more anesthesia, and waited for him to just calm down and secure the side ports to avoid any leak. And then when I started to feel that the patient is calm and is not agitated and the eye is quiet, I went in again and I dilated the pupil with iris hooks, and started to manipulate the lens. It's as you can see, it's a thick lens, and it's not easy to manipulate around. So I wanted to tuck it in the bag without endangering the posterior capsule, which is at a high risk of rupture in these cases. And also working in a tight and small environment and a very shallow anterior chamber also poses a risk. So I used a lot of OVDs and manipulated it slowly and gently out of the bag and in the bag several times until I could achieve putting it in the bag again. Now, one of the other options, just in case I thought that this is endangering the bag and I didn't want to sacrifice it, is opening a wound and taking out the lens and loading it in the injector again and reinserting it. But this would give me a risk of keeping the eye open on a larger wound that I did not want to risk for a long time. So I was lucky that after a few manipulations that the 2 haptics could sit in the capsular bag. And as you can see, the lens is a little bit large for the eye, and this is what is characteristics of nanophthalmia, is that the lens-eye relationship is a little bit exaggerated or increased. And so at the end, as you can see, I could just put it in the bag. And because there was a lot of manipulation, I did give the patient steroids at the end of the procedure. And I also took out the viscoelastics, made sure to spend some time taking out the viscoelastic that I used generously in this case. And I also fashioned a peripheral iridotomy. As you can see here in this clip, that I don't remove my second instrument suddenly. I maintain the anterior chamber formed at all time until I secure my side ports, and I fashioned a PI, peripheral iridotomy, because there was a lot of pigment dispersion, and during the case, I wanted to avoid pupillary block, which could happen in a large case of a number of cases in these patients.
So yes, this recording and this lecture just saved me from apologizing from presenting in this session. And the message that I want to convey that as women, we have special circumstances that make us sometimes run an extra mile or pay extra dime in order to achieve whatever standard we have achieved. And it's always about balance. And being surgeons or doctors or merely physicians, it's always about how we manage. For me, how I manage and look at complicated anterior segment cases, I do risk stratification in order to find the solution. The same as how I manage my house, my children, the presentations, my commitment to being safe. So there's no need to compromise social responsibility for professional duties, and work-life balance is key to the success. This is just a poem I came across. So mirror, mirror on the wall, I'll always rise after I fall, and whether I run, walk, or crawl, I'll set my goals and achieve them all. This is thank you to my fellows and team who are looking after my patients in my absence. Thank you very much for having me here.
Thank you, Nancy. أتمنى السلامة لأمة أبوت. We hope everyone to get well from this corona, and peace upon everyone around the world. And now I'd like to introduce Dr. Nihal Shqanqiri to give her talk in the pediatric cataract surgery with the posterior capsule defect.
Bismillah ar-Rahman ar-Rahim. Before I start, I'd like to thank Dr. Muhammad Al-Amri for inviting me to participate in this meeting and to join these eminent female ophthalmologists speaking about ophthalmology. And I'm going to speak about how to perform a congenital cataract surgery in the presence of posterior capsule defect. During pediatric cataract surgery, it is not always beautiful and easy to have a straightforward, transparent posterior capsule where we can go for a classical posterior capsule rhexis by hooking the posterior capsule and then tenting and then tearing into a triangular tear where you inject viscoelastic into the burger space, and then here you can see this is the ring in the viscoelastic into the burger space. And then through this triangular tear, you can hold the posterior capsule and perform a straightforward, exactly 4 millimeter posterior rhexis. And then you can implant safely intraocular lens. Sometimes when dealing with a congenital cataract, as in this infant, especially when you have a very well-defined opacities, you are faced with a problem of congenital posterior capsular defect. Congenital posterior capsular defect can be very well evident against a bright red reflex. And the lens mirror inside the defect can be seen here like that, either partial opacification within the defect or total opacification of the lens blocking the defect. And the background lens may be transparent, as you see here, against red reflex, or the lens may show pearls like this, and see here, this is the defect. Or the defect may be hidden under total cataract, but you can see, still you can diagnose the defect easily. The defect may vary in size and in shape. It may be a circular posterior capsular defect. And this circular posterior capsule defect may be of a transparent edge. it looks like a posterior capsulorhexis. And sometimes this defect may be surrounded by fibrosis like that. The size of the posterior capsular defect may vary. Look here, this is a tiny opacity, which actually block the small, tiny posterior capsule defect. Or it may be a small defect. Or in this case, can you see this halo here? I don't know whether it is visible or not. And it coincides with a moderate size posterior capsular defect. And sometimes the circular defect is huge. This is before surgery, and here during surgery, it's a huge rounded or circular defect. It may be associated with other congenital abnormalities like microphthalmia, microcornea, and undilatable pupil. Look here after multiple spectrotomies. Can you see this halo? It coincides with a large posterior central defect. Sometimes the posterior capsular defect is triangular, as in this case, or it may be elliptical. And the elliptical defect, it may be horizontally oriented, as here, or maybe vertically oriented. Look here before surgery and here during surgery, vertical. It may be centrally located or maybe eccentric. In cases with eccentric posterior capsular defect, it may be associated with pigmentation around the defect, which gives the impression that this maybe it's a sort of a variant of posterior fibrovascular sheath of the lens. The elliptical defect may vary also in size. It may be small in size or maybe a large elliptical defect. The size of the defect is not important, but what is important is the relation of the posterior capsular defect in the relation with the anterior capsular axis size. So if the defect lies within the vicinity of the anterior capsular axis, so it means that it is possible to implant intraocular lens inside the capsular bag. But if the defect is large and beyond the edge of the anterior capsular axis, it means that we will not be able to implant inside the capsular bag, as we're gonna see. Another issue is the lens obstructing the defect, the lenticular opacity which obstructed the defect. It may lie anterior to the defect, and in these cases, we have a transparent anterior vitreous face. Or sometimes the lens matter lies behind the defect, and here you can see the defect. So in these cases, it is associated with vitreous opacities in the anterior vitreous face, and these are dispersed lens matter. Look here, this is an elliptical defect, and the blocking lens lies in the Berger space, in the anterior vitreous face, behind the defect. And that's why you see here, this is the elliptical defect and associated with opacities in the anterior vitreous face. So when we come to the surgery, cataract surgery without intraocular lens implantation, we want to go for a rhexis 6 mm anterior rhexis and a 6 mm posterior rhexis and anterior vitrectomy. So how to deal in these cases? Once we suspect a case like that with a posterior capsule defect, we don't go for hydrodissection nor hydrodenylation. And once we are in for irrigation aspiration, we are never out until we finish irrigation aspiration. Look here, we can see the defect while performing the irrigation aspiration. After irrigation aspiration, we have this elliptical defect. How to proceed? We can go and cut the edge of the rhexis and the opening, the defect, and then we go with the rhexis forceps in order to perform a 6 mm posterior rhexis. And now the vitreous opacities can be cleared up with a vitrectomy and perform anterior vitrectomy. And now it's a simple case of a pediatric cataract. Sometimes we are faced with what is called double defect. A double defect, there is a defect in the posterior capsule and a defect in the anterior vitreous face. How to proceed in these cases? Again, we cut with the micro scissors the defect, and then with the rhexis forceps, we complete it into a 6 mm rhexis, clear the vitreous, and now at conclusion of surgery, it's like a simple case of congenital cataract. Another technique is that when you suspect the defect. After irrigation aspiration, look here, the defect started to appear. After you finish irrigation aspiration, this is the defect. You go out with the aspiration, and then you go in with the cutter, and you trim the edges of the defect until you have the desired size of posterior capsulorhexis. And this can be done in all defects and all sizes of the defect. In cases of a tiny defect like that one, here you can perform the rhexis with a cutter, and then you trim it to the desired size, 6 millimeter, and here at conclusion of surgery. Some cases when like that, when you have a calcification blocking the defect, this is the start of the defect here, and here after irrigation aspiration, again with a cutter. This is a small defect, this is small posterior capsulorhexis, you can increase it with a cutter to the desired size, and here 6 millimeter at conclusion of surgery. This is a large defect, again with the same thing. After irrigation aspiration, this is elliptical defect and there is no vitreous prolapse. Very important thing here in these cases that you should have a very good anesthesia with a good muscle relaxant in order to avoid prolapse of vitreous in these cases. And then here again, increased to the desired 6 millimeter posterior rhexis. What if we're gonna go for a cataract surgery with IOL implantation? In these cases, it depends upon the size of the posterior capsular defect. In cases of a posterior small defects like that, it's very simple and easy to go as if we are performing the conventional 4 millimeter posterior rhexis around the defect and then clear the vitreous, and we can implant inside the capsular bag. But in cases with a moderate size defect, still we can cut the edge of the defect by scissors and then complete it into a circular opening by the rhexis, and we can still implant the intraocular lens inside the bag between the anterior and posterior rhexis. In cases of moderate defect, like here we expected to have a moderate size defect, but we have fibrosis in the posterior capsule. In these cases, we have to take care while performing the posterior rhexis. Partly is performed by the rhexis forceps and partly is performed by the scissors. But take care, the junction between the fibrotic posterior capsule and the transparent one is very weak and is liable to tear. So care should be taken while implanting the intraocular lens inside the capsular bag between the two rhexis. What about large posterior capsular defect? As I told you, it's very important to see this defect in relation to the anterior capsule, anterior capsulorhexis. If the defect lies within the vicinity of the anterior rhexis, so it is possible to cut the defect and then complete into a circular opening, clear the vitreous. You have here the anterior and posterior capsulorhexis, and then you can inject the intraocular lens inside the capsular bag, despite having nearly of the same size of even the posterior rhexis is larger a little bit than the anterior rhexis, but still you can implant inside the capsular bag. But if this large defect goes beyond the edge of the anterior capsulorhexis, so what to do actually in these cases, we're going to remove the whole posterior capsule, eating it up by a cutter, and then implanting the intraocular lens in sulcus, and then performing optic capture technique. But take care when performing posterior, in these cases with a large posterior capsular defect, the key of success is the size and the centration of anterior capsulorhexis. After dealing with the posterior capsule and removing the whole posterior capsule, you're going to have a beautiful 5 millimeter anterior rhexis and implant the IOL in sulcus. You should see this picture. The anterior capsulorhexis should be exactly 1 millimeter inside the optic, centrally located like that, so it is possible to push the optic underneath the anterior capsulorhexis in a downward position, and then push the upper part of the optic behind the anterior capsulorhexis, and you're going to have a beautiful optic capture technique. Take care while dealing with the total cataract. Sometimes it is totally hidden. Look for the other eye. Look to this child. He has a total cataract in the left eye, and in the right eye, he has, this is with magnification, and here under a microscope, he has a large posterior capsular defect here during surgery. So when dealing with the cataract in the other eye with a total cataract, you should suspect that 100% you have a posterior capsular defect. So you should take care. This is a perfect anterior capsular axis 5 millimeter. Don't go for hydrodissection, hydrodelineation. Look here during irrigation aspiration, you have here the defect started to appear, and here is the defect. You have to go first with a dry vitrectomy. You want to know the exact size and the exact extent of the defect. Here, after vitrectomy, we saw that the defect did go beyond the edge of anterior capsular axis. So what to do again? Remove the whole posterior capsule, implant the intraocular lens in sulcus, and then push the optic behind the anterior capsular axis to perform optic capture technique. And this, and here, even in cases with a peripheral defect, again, remove the capsule, implant in sulcus, and perform optic capture technique. And this optic capture technique, how it appears after surgery, beautifully centered. And the IOL optic is behind the anterior capsular axis, so it has all advantages of capsular IOL. And finally, to conclude, when dealing with cases of congenital cataract, it is not always simple and easy like that. When you see a total cataract, maybe it is hiding a posterior capsular defect. You have to know exactly what to do. Here a total cataract, and here hiding a large posterior capsular defect. You know how to deal with these cases in order not to push the lenticular matter into the vitreous and have complications, in order to perform a safe and sound surgeries to these adorable little angels, because they deserve the best, and in order to draw these beautiful smiles on the faces of the infants and in children after having a beautiful cataract surgery without complications, in order to prevent blindness in these angels. And thank you very much for your kind attention.
Thank you very much, Dr. Nihal. As usual, very interesting presentations.
Can I say something?
Yes.
Dr. Nihal, congratulations. This is very nice talk, actually, and actually, I would like to congratulate you on the clear. I'm amazed by your pictures for the clarity of the OR image. So which system are you using? I'm amazed.
You mean the microscope? Yeah, I'm using Lumera 700. And,
that's nice.
Yeah, an Apple system for recording.
Apple system. Okay, nice.
Yes.
Thank you. Congratulations.
Thank you.
Now we are welcoming Dr. Khadija Al-Attas talking about AMD from A to Z.
Hi, good evening, everyone. I'm Khadija Al-Attas, assistant professor from King Abdulaziz University. Let me share with you my presentations. Just hold a sec. So good evening. Thank you to Dr. Fatma and Dr. Muhammad for letting me to participate in this meeting. I'm Khadija Al-Attas, assistant professor in King Abdulaziz University, Jeddah, Saudi Arabia, retina consultant. Today I will present about the AMD in a very simple way, because I think it's a bit underestimated and misdiagnosed in our region. I have a lot of patients with misdiagnosis and mistreated. A lot of patients come to my clinic complaining, very, very disappointing. They have diagnosed with a DR, and they've been treating on injection for a very long time, despite their good blood sugar, despite their good hemoglobin A1C, and they keep treating them with injection as a diabetic retinopathy. When I examine these patients, I figure out they don't have a DR, they are simple AMD with wet AMD. So in this lecture, I'm aiming the general ophthalmologist, the residents, to understand the basic of AMD, to facilitate the understanding of this disease in our region. I will share some of my result of my two ongoing researches. One of them about the percentage epidemiology on the nature of this disease in our region, especially the western region of Saudi Arabia. The other one treating the AMD patient in the era of the COVID. Okay, as just hold a sec. Sorry. As we can see, AMD count almost 6% of causes of blindness among the adult aged 50 years old and older in the globe, and almost 16% in the developed countries. AMD, the major cause of central visual loss in the developed world, affecting more than 10% of people older than 65 years and more than 25% of population older than 75 years in the US alone. Almost 2 million individuals have advanced AMD and more than 8 million individuals have intermediate form of this disease. This number will duplicate in the next year. In Saudi Arabia, the last study showed that AMD represents almost 3.3% of the major causes of blindness in individuals older than 50 years old. There is no recent study with accurate percentage, especially in my Western region, as I said. Visual impairment in elderly people with considerable health problems that significantly affect quality of their own lives worldwide. The magnitude of this issue is becoming more evident with an aging population and increasing the number of older individuals. AMD is an acquired disease of the macula characterized by progressive visual impairment because a late onset of neurodegeneration and the photoreceptors of retinal pigment epithelial. The object of this talk view is clinical and pathological aspect of age-related macular degeneration, diagnostic tool, therapeutic modalities, presenting available and underway of both atrophic wet form of the disease. AMD is painless, irreversible degenerative eye disease associated with the damage of unlimited death of photoreceptors. Dry, and there is two types, dry and wet. The dry one is the more common, almost 80 to 90% of the disease, but the wet kind, almost 10 to 20% of the disease, is usually more advanced disease state and associated with the rapid distortion and sudden loss of central vision. The dry form of AMD, also known as non-vasculars or atrophic kind, it's more common, as we said. The visual loss in dry AMD, gradual and usually associated with a moderate visual impairment, as well functional limitation, including fluctuating visions, difficulty in reading, difficulty in driving at night, limitation of vision at night. The histopathology of this dry type, characterized by drusen deposits located in the interface between the retinal pigment epithelium and Bruch's membrane. The drusen are lipid-like crust deposits which can accumulate naturally in the with the age. Drusen disturb this normal function and overlying retina. As we can see here, stages of AMD. These classifications, we have a lot of classification of AMD. The age-related macular degeneration study classified most commonly used. Approximately 20% of dry AMD will transfer to wet AMD. The wet AMD, which is count almost 10% of the cases, but it's more aggressive. A number of studies demonstrate that in patients with wet AMD, the eyes have 2 times the expected prevalence of vitreomacular adhesion and they have less likely to have BVD. Fluid and exudate may accumulate underneath the retina patients and with the neovascular AMD resulting in severe macular edema. The histopathology characterized by choroidal neovascular CNVM, abnormal growth of blood vessels, complex penetrating through the Bruch's membrane and choriocapillaris. CNV characterized by immature blood vessels that are usually leak and accumulate beneath the retina. The accumulative blood and fluids disturb the overlying retina and resulting of visual loss. It has been observed that choroid capillaries thin in the patient of AMD, which may contribute with the decline in the removal of extra materials that result in drusen formation. The exact pathophysiology of the AMD is not fully understood. However, finding from ongoing studies that expanding our knowledge of the disease and underlying mechanism, it's believed that the pathogenesis of AMD is a result from the complex multifocal interaction between metabolic, genetic, functional, and environmental factors. For me, this is the most important slide because if we could know the etiology or the risk factor, we can control this disease. The strongest predictor of the AMD is age. Risk of acquiring increase more than 3-fold in the patient older than 75 years compared to the patient between 65 and 47 years. The family history and the genetic, as it's most commonly frequent in the Caucasian and Hispanic and Asian, and less common in African American. Smoking will double from 2 to 4% of 2 to 4 folds of the patient to have AMD. Also, the high blood pressure, obesity, hypercholesteremia, atherosclerosis. Studies shown that the high energy visible light, like sunlight, can cause AMD. And also the study showed that a woman have more risk to develop AMD more than the men. The diagnosis of AMD in the early stages is usually asymptomatic, but in some cases, patients may complain of acute visual loss, metamorphopsia, blurred vision, scotoma, and chronic visual distortions. Since the onset of the AMD gradual and often unnoticed for a long time, we recommend the routine dilated examination and the routine fundus examination are very recommended. There is a lot of modalities for screening tests like visual test, a visual acuity test, dilated fundus examination, optical coherence, fluorescent angiograph, and fundus autofluorescence. Amsler grid is very good tools to use at home to monitor the progression of the AMD. And there's a lot of digital apps have been developed to assist patients with visual impairment in their daily activities. As we can see, there is this is the two kind of AMD, the dry one and the wet one. The main manifestation of the wet one to having CNV and pigment epithelial detachment. The OCT has approved to improve the understanding of microstructural changes related to the AMD. We can classify the CNV to occult and the classic one. For the treatment, there's a lot of strategies managed AMD has been used, including laser photocoagulation, for the new vascular AMD, submacular surgery, external beam irradiation, and focal radiation, intravitreal steroid. And these modalities demonstrate no efficacy and was with a lot of adverse effect. Nowadays, the treatment of dry AMD, current management of geographic atrophy in AMD basically depend on the documentation, observation, surveillance of the early recognitions and changes of visual function, like a CNV, at the treatable stages. The ARDS study shows that using a patient with a mild or moderate form of a dry AMD and using antioxidant, they have small but very defined decrease in their progression to a wet AMD, to advanced AMD. And the data also showed that benefit of preventing conversion from the dry type to the wet type. This is the message for the family and the members of the patient with the AMD. Don't smoke, avoid unhealthy food, protect your eyes from the sun, eat well healthy diet with a natural antioxidant, eat fish, eat leafy vegetables, and consider the supplements. This is the evolutions of the treatment of neovascular AMD. Before 1980, there was no treatment. In the early of 1980s, we have thermal lasers and they will start photodynamic therapy in 2000s. 2005, we start the anti-VEGF. Based on the angiogenic rules of vascular endothelial growth factors in the new vascularization, VEGF inhibition has become one of the targets great successful treatment for the AMD. Currently, we have 3 or 4 widely used intravitreal injections, anti-VEGF, like Lucentis, Eylea, Avastin, have proven a highly effective treatment that can effectively prevent legal blindness in patients with the wet AMD. We have a lot of regimens to use anti-VEGF. We started monthly, we have quarterly, BRN, bi-monthly, treat and extend. However, there is a compelling need for long-lasting therapy solution for the patient with AMD because of the cost of the drugs, patient access to the adherence for the treatment, and increasing burden of frequent office visits, receiving injections, especially in population age. Considerable research effort continued toward developing extend and release therapies that intraocular drug delivery device. This is some of the summary of the most important result of the studies. For us in our region, I figured out that the patient come in early ages, like mid 40s or early 50s, and they have aggressive form of the disease, very extensive subretinal hemorrhage. I think the quick lifestyle or the style of eating fast food, smoking is the cause of this early manifestation in our region. At conclusion, several risk factors have been linked to AMD, such as age, lifestyle, smoking, diet, family history. Although the pathogenesis of AMD remains unclear, genetic factors have been impacted in the conditions. Treatment of atrophic AMD, mainly close observation, coupled with nutritional supplements such as zinc and antioxidant. Treatment of wet AMD based on targeting the choroidal neovascular membrane. Identification of modifiable risk factor would be improved. Possibility of preventing the progression of AMD. The role of antivascular endothelial growth factor anti-VEGF agent has transformed the therapeutic approach of the potentially blind disease with AMD to more favorable outcome. Thank you so much.
Thank you, Dr. Khadija, for this nice journey from A to Z with AMD. Now I'd like to invite Dr. Amal Waraiqat to give her talk in Yamani circus IOL fixation and clinical outcome and then more than 150 consequent cases. Dr. Amal. Amal.
Thank you so much. I will share my screen, and thank you so much, Dr. Mohammed Al-Amri, for the kind invitation. Very interesting and wonderful subjects in this meeting. Okay, so today I'm going to talk about the clinical outcomes of Yamani intrascleral haptic fixation and my experience in the first 150 cases. I have no financial disclosures. So anyone can have a situation with a PC rupture. First thing, you should not panic. You should always start with the ABCs. Do not withdraw the phaco probe immediately. Do not leave any residual cortex. No vitreous is allowed to stay in the anterior chamber while implanting the secondary IOL. No cystoid macular edema. And at the end of the surgery, we should have a stable IOL in a stable and appropriate location. So if you have a small PCR, then we can do a small posterior capsulorhexis and put the IOL in the bag with a 1-piece or a 3-piece lens. If we have a large PCR, then we can implant the 3-piece IOL in the sulcus with a posterior optic capture, or we can place a single-piece lens in the bag with anterior optic capture if we have to have a 1-piece lens. If we have, for example, multifocal lens, or for any other reasons where we need to place a single-piece lens. If we have no capsular support, then we have many options. We have the iris claw lens, the iris fixated lenses. We have the iris sutured IOLs. We have the transscleral fixation, the scleral fixated, scleral sutured IOLs, and the Yamani intrascleral haptic fixation. So my journey with the Yamani intrascleral haptic fixation started in September 17, 2017, when I did my first case. I had 230 cases until the date of preparing this presentation, and we had 150 cases with a minimum 1 year follow-up. So the diagram for the flanged haptic IOL technique, we have to have a good pressure in the eye, whether having an AC maintainer or filling the anterior chamber with viscoelastic, the main incision, and then we do the marks at 0 and 180 degrees, and then we put the marks for at least 2 by 2 millimeter behind and away from the limbus. I use the 30 gauge thin wall needle for the Yamani technique. So those are the perfect needles for this technique. So our study purpose was to present the visual outcomes and the complications of the anterior vitrectomy and the Yamani intrascleral haptic fixation done by a single anterior segment surgeon. This was a prospective non-comparative case series. We had 150 eyes, and we had 2 angled incisions that were placed 2 millimeters behind the limbus. We externalized the haptics of the IOLs, and they were cauterized with a low temp cautery and then pushed back into the sclera. So we had 150 eyes. The age range was 6 to 87 years, and the male to female ratio was 2 to 1. The preoperative visual acuity improved to 20/25 at the end of the first year with a significant p-value. The type of the lens that was used, we used the ZA 9003 in 139 of the cases, and we used the MA60 AC in 11 cases. We don't have CT Lucia available in Jordan, which is the 3-piece lens with the PMMA haptic, with the PVDF haptic, which is the perfect lens to be used for this procedure. Those 2 lenses have a PMMA haptics. So I will go quickly over this video that shows the technique pearls for this procedure. So we place an AC maintainer. We put the marks at the beginning of the procedure. They should be exactly 180 degrees apart. The main incision should be at 90 degrees away or in the between those two marks. I insert the 3-piece lens, and the leading haptic should sit anterior to the iris. I do this trick. I mark the needle at 2 millimeters from the tip, so that will guide me to change my direction when inserting the needle in the sclera. Once I reach this mark, I change my direction of the needle toward the center of the eye. Then I direct my attention to the opposite paracentesis. I place the intraocular forceps, and I dock the haptic of the 3-piece lens into the lumen of the 30 gauge needle. What I like to do here is to externalize the leading haptic, cauterize it, so that I will be feeling safe that this will not go inside the eye. So I do cauterize without touching the haptic. I don't push it completely into the sclera. Now I change my attention to the trailing haptic. I insert it into the anterior chamber, and we do repeat the same process. This one is a little bit challenging, but with practice, it can be easy. So I use the tip of the needle to push the optic to put the lens in a more appropriate position for the docking technique. So we dock the trailing haptic now into the lumen of the 30 gauge needle. I externalize it, and then I do cauterize. I prefer here to use the needle on a syringe, like to use it as a handle, and fill it with BSS to avoid having the bubbles in the anterior chamber. And then I check the centration of my lens, if there is any tilt, if I need to trim the haptic on one side more than the other side, just to make sure that the lens is perfectly centered. So some of the indications: subluxated lenses, Marfan eyes. This is one of my cases as well. This is the appearance of the eye on 1 day post-op. It looks amazing, as if it is not touched, which is not common to be seen with all other types of scleral fixated lenses. So this is the best view that you can have of an eye with a secondary IOL. So this is a small video about a Marfan patient. We do the same procedure, but we know that the lens sometimes is subluxated, and this is one of the indications to do the surgery. So the capsulorhexis might be challenging in those cases. It's very important to have a centralized capsulorhexis, and also sometimes it's even difficult to puncture the capsule and initiate the capsulorhexis. At this point, I use the capsule hooks to stabilize the bag and to make the phaco procedure possible. I proceed with the phacoemulsification, and I do viscodissection before inserting the capsule hooks so that I will not entrap any cortical fibers. I use the capsule hooks, as I mentioned. Those are MST capsules. They come in different forms. We do the phacoemulsification, and I decided in some of the cases to keep the bag and do the Yamani technique in a supracapsular technique. So I will do the Yamani intrascleral fixation. I will push the optic in the bag, but I will keep the bag so that the vitreous will not be interrupted in those patients. As we know, those have a higher incidence rate of retinal detachment, and sometimes they need a pars plana vitrectomy for this procedure to be done safely in those patients. So what we do here, we push the optic in the bag, we do the Yamani technique, and we keep the bag. So this was a small study about the visual outcomes of the Yamani intrascleral haptic fixation in a special group of Marfan patients. We had 10 eyes. In 5 of the cases, we kept the bag. In 5 cases, we did pars plana vitrectomy with the aid of the retina team and a Yamani intrascleral fixation. So the age range was 6 to 37 years. The visual outcome improved to 20/25 at the end of the first year. We had transient vitreous hemorrhage in one case, and we had a dislodged optic haptic junction in one of the cases where we used the MA60 AC. And from my experience, I learned that the MA60 AC from Alcon company, it has a weak optic haptic junction. So I do not advise this lens specifically to be used in Yamani intrascleral fixation. So the indications for our study was subluxated IOL in 39 eyes, subluxated lenses 15 eyes. We had surgical aphakia in 42 eyes, traumatic aphakia in 23 eyes. We had cataract with zonulopathy in 24 eyes. And I had 6 eyes with ACIOL with decompensated cornea. And I had to exchange the lens for the DSEC procedure that will be following the dealing with the lens. And I had a case with a decompensated cornea with an iris sutured IOL. The complications varied from ocular hypertension, transient vitreous hemorrhage, transient cystoid macular edema, iris capture, IOL tilt in the degree of 2.8 degrees, and we had a broken optic haptic junction in one case. We used different ways to measure the IOL tilt, UBM microscopy, anterior segment OCT. So before the pearls to learn this procedure and to master it, before doing your first case, always be ready. There are skill transfer labs, whether in the American Academy, in many meetings, we can find the wet labs that will teach the beginners how to start doing this procedure. This is a simuli where you can learn how to do the procedure before starting this on your first patient, actual patient. And it completely mimics the procedure on a human eye. So I advise starting on those eyes. The lenses that are used, so I use the MA60 AC, which is a PMMA haptic, the thickness ZA9003. Both of those lenses has a PMMA haptic, but the ZA9003 had a stronger optic haptic junction. The best lens, as described, is the CT Lucia from Zeiss. This has a PVDF, so it is resistant to kinking and to a lot of manipulations. The So this is the appearance of the PMMA lens and how it, can kink. This is the CT Lucia lens, which resists the kinking and the manipulations. This is the appearance of the bulb when it is created on the CT Lucia lens. It forms a mushroom tip-like or a mushroom head, which is difficult from the PMMA. It forms a tapered end appearance. This lens, which is not available also in my area, I practice in Jordan. This is a Santen lens, which I think was described by Dr. Shen Yamani in the beginning, and I think he performed most of his cases on this lens. So this is an excellent lens because this is a 3-piece lens. The haptic is made out of PVDF. The overall diameter is 13.2 and the optic diameter is 7 millimeters. So it is resistant or is more forgiving for decentration. So some of the pearls for this technique, you should always start by marking before entering the eye, before creating any paracentesis, so that your marks will be very nice and clear. And once you dilate the eye, you will not know where is the center of the lens. So this is very important to start with. Avoid high temp cautery. So we use low temp cautery in this procedure because high temp cautery will result in excessive shortening of the haptic. We need sometimes to trim the haptic for better centration. So don't push the knobs inside the sclera until you are sure that your lens is very well centered. We need to push the flange within the sclera at the end of the surgery. It should be intrascleral. So this is a Yamani intrascleral fixation. It should not be exposed on above the conjunctiva. The haptic, as I mentioned, may break. It may break at the optic haptic junction. This is an MA60AC. I had externalized the leading haptic. Then I had to cut the lens, take it out, and then cut this bulb before taking the lens out. Sometimes we need to work with our colleagues, with the retina team, because the lens might not be stable, so it might need a posterior approach, such as this case. And we need to be comfortable with vitrectomy, whether an anterior or a pars plana vitrectomy. This is an important part of the procedure because there is some manipulation and we don't want to do any traction of the vitreous. Sometimes we might combine the procedure with other procedures. For this case, this is a patient who had a traumatic cataract, a traumatic dilated pupil. So we had to do pupilloplasty before doing the Yamani intrascleral fixation. This is the some of the eyes, the pre and the post-op appearances of the operated eyes. This is a case where we had a dislocated patient who was referred to me with a subluxated iris claw lens, a posterior one. This patient has a persistent cystoid macular edema and a persistent uveitis, so we had to remove this lens and replace it with a Yamani intrascleral fixated lens. So the Yamani intrascleral haptic fixation is a very reliable technique for the IOL fixation in the absence of capsular support. Clinical judgment is very important in all the cases because no single surgical technique fits all the cases, and the surgeon's technique of choice depends largely on his experience. Thank you so much.
Thank you, Dr. Amal, for very nice and valuable presentation. Now I'd like to share all our panelists and co-moderator if they have any question or any comments in our presentation, which be given.
Congratulations to everyone presenting. This is Vaidehi Didania from New York. Those were excellent presentations. I had a question about, when you're doing the Yamani. So I agree, I've had similar experiences. I'm a posterior segment surgeon, so I've had similar experiences with the haptic optic junction breaking. So when it breaks, do you, what's your next planned procedure? Do you go ahead and implant the same lens and try again, or do you use a different technique? For example, I've talked to patients before about an acryos at the time if it breaks.
Yeah. Thank you so much for your question. Actually, we had one case out of 230 cases. With experience, I feel very comfortable with the Yamani, and I feel that it is one of the safest procedures. I used to do the iris sutured IOLs and the scleral sutured IOLs with the Hoffman pockets in the beginning, but I switched my practice to the Yamani. So I have a backup lens, and I learned that I should avoid the MA60AC because this is the single lens with that is the lens that is most liable for the optic, haptic junction dislodging. With the ZA9003, the things were okay. So I will go ahead. We had one patient where, when we had this accident, so I cut the lens, I took it out, and I did not have, a replacement lens at the moment. So we had to wait for another 3-piece lens, but the ZA9003. So I will try the Yamani again.
Yeah, some of our locations, we don't have the CZ Lucia lens. And so the only time I will do the Yamane is if the MA60 is already in the eye. So I'll attempt to rescue it, and if it's not possible. The only thing I found that helps is maybe pulling up that nasal haptic first and doing the scleral fixation because of the nose getting in the way, and then temporally I'm able to bring it up easier.
Yeah.
Great cases, everybody. Thank you.
We have a question from our audience. Which lens do you use for the scleral fixation? Dr. Amal, I think you answered this question.
Yeah, so it depends which lens is available in your area. Like if I'm in the US, I will prefer to use the CT Lucia because of the PVDF haptics. But what I have is the ZA9003, and it works great in our hands. So I use the ZA9003. And then the second option is the MA60AC from Alcon. The simulator eye, there is another question about the simulator eye for the training. It's called Simul Eye. If you don't mind, I can share my presentation again, and I'll show you the picture, and you can email me if you like, and I'll give you the contact details for the company. Actually, I am a part of the wet lab, the Yamani wet lab at the American Academy for the last 5 years, and we've been using this this simulated eye for training. It is amazing. Let me just go back.
I think in our region it's from Amico or Alcon company.
So the provider is in the US. I can. This is the name, Simul Eye. Ophthalmic surgical training models, and I can maybe if you reach me by my email, I'll send you the contact details for this company.
Yep, in our region.
I don't know if there is any representative for this company in our region. Actually, we had to contact people in the US, and that's how we brought it to Jordan and in our wet labs.
So Khadija, I think you know in Saudi it's available, right?
Yeah, I'm not sure if it is available in Saudi. In Jordan, it's not available.
It's available in our region, I know. I attend one course. Okay, and then Dr. Paula, any comments, and Dr. Asmat, want to hear your voice?
Yes, hello everybody. Thank you for very nice presentations. I'm proud to have two of my colleagues in this session, Dr. Nancy and Dr. Amal. Thank you, very, very nice presentation. Dr. Amal, one question for you about Yamani in children. What's your experience? If you did any kids?
Yeah, so actually the youngest I did is 6 years. It was a patient with a traumatic aphakia, and it went very well. I had another patient with Marfan syndrome. It was a family who had a subluxated lenses, and the ages were 6, 8, and 12. And it was nothing different from the adults, but I wanted to, in the Marfan patients, I wanted to preserve the bag, although it is subluxated. So I did the Yamani technique, and then I pushed the optic in the bag. I kept the bag because, you know, I wanted to avoid any manipulation of the vitreous and having any risk of vitreous retinal detachment in the future. So I used the, and I think this is a new procedure to keep the bag while doing the Yamani technique. It is a supracapsular technique. I feel that this is a safe way to do Yamani in Marfan patients, especially in the pediatric age group.
So brilliant.
Thank you so much.
Thank you.
Really. Thank you for all ladies. So Paula, you want to see something?
I just wanted to ask a question to Dr. Amal. I am a glaucoma surgeon, and I just wanted to know that, do you get post-operative IOP spikes or secondary glaucoma post the Yamani fixation of the scleral IOL?
Yeah, thank you, dear, for this question. Actually, in the beginning, I used to do the AC maintainer, but then I moved to put a viscoelastic in the anterior chamber in order to maintain or to have a good pressure in the eye. So sometimes we have a spike in the IOP. We check the IOP in the first day, and we discharge the patients on Diamox anyways, you know, just to, in anticipation of IOP spikes in the first few days. But in our cases that were followed up for 1 year, we did not have a persistent glaucoma. We had a persistent, you know, an IOP spike in the first 1 or 2 days. And most of this was directly related to some viscoelastic that was left or that, you know, went into the posterior chamber. But we did not have a persistent IOP rise in those patients.
Thank you. It was perfect. The presentations were amazing, all of them.
Yes.
Really.
I would like to
that we are among all these beautiful ladies. Of course, the man doctors are our brothers and colleagues, and we appreciate them. But such a nice event that we all will be together without any interrupted demands.
Yeah, especially Dr. Nancy, her parents in the hospital. Our prayers for them, Dr. Nancy. I'm glad you could do it. And yeah.
I have a question for Dr. Nancy.
Yeah.
Nice to meet you, by the way. You gave a great talk. Thanks so much. I've learned a lot. I have a question, a general question for you about the non-ophthalmic patients and during cataract surgery in those cases, and even in patients with small axial lengths and without non-ophthalms, you know, in those cases with short axial lenses generally, do you routinely perform iridozonal highlighter vitrectomy just to prevent development of malignant glaucoma? This is the way I do this surgery. So what do you think about it?
Yeah, I started doing the first case like 4 years ago, and I had a number of patients. They're 15 with extremely non-ophthalmic. I'm not talking about an axial length less than 20. I'm talking about extremely non-ophthalmic eyes, 16 and below.
16.
Yeah, and I had 3 siblings. This is one of the siblings that were with bilateral non-ophthalmia of 13 and 14 millimeter axial length and very high OL powers, 54 and 60, and very high OL. So this is an extreme non-ophthalmia, which is the most dangerous. I was equipped, and I told the patient, the first eye of the first patient, that I might need to do this. And my VR colleague was just beside, waiting to interfere. But things went smooth because I already gave them a Diamox at the night of the procedure and mannitol just half an hour before, so everything went fine. And even you can see this. This is the toughest situation I've went through is the second eye, when I couldn't just tuck in because there was pressure, a positive pressure. And I was ready to go in and do some just limited vitrectomy, but I didn't have to in any of the cases.
So I mean, iridozonal highlighter vitrectomy as a prophylactic measure for development of malignant glaucoma. I mean, creating a unicameral eye for the risk of malignant glaucoma for maybe for a couple of months after the surgery. You know,
yeah, because
this
I
might
don't
happen
do
in extreme short eyes, in extreme less than 16 millimeters, as you said.
I wish I could do that. So I would just protect myself from the panic, but I don't do this procedure. So, but if you would do it, it's better.
Okay, thank you.
Luckily, I haven't had.
Yeah, it works really well, actually.
Oh, I'm sure it is. Yeah.
Yeah.
We're doing fine till now. Yeah.
Yeah. Congratulations for your surgeries. They were awesome.
Thank you.
Thank you.
I think we should conclude in our session. Thank you for everyone. Really, it's a very late time in our anyway time. It's 11 o'clock around. And thank you for everyone sharing and participate with us in our conference. And I hope we will see you again and again and again. Thank you very much and good night.
Thank you. Bye.
Honor.
Thank you. Have a good night.
Okay.